Okay, so welcome everyone. I'm so pleased to introduce Sofia Ahmed to our Women's Health Seminar Series. She has been an active participant in the cluster, as well as some of her trainees are on many of our committees, and we really appreciate the University of Calgary representation, I guess, within the cluster. So before I introduce Sophia, I wanted to do a land acknowledgement. I want to recognize that we live, play, work, and participate in a community on the unceded, ceded, and traditional territories of the 203 First Nations, along with 38 Métis chartered communities, each of which possess their own unique traditions and history here on this land that we now refer to as British Columbia. And I recognize, of course, that many of you are not coming from British Columbia. So I urge you to please take a look at some of the ancestral lands that you are currently living on. We acknowledge the importance of the Truth and Reconciliation Commission of Canada's call to action, the United Nations Declaration on the Rights of Indigenous Peoples, and the BC Declaration of Rights of Indigenous Peoples Act. In all of our work, we're committed to ensuring Indigenous women's rights to health and safety and the equal opportunity to participate in a manner that recognizes and respects Indigenous cultures and traditions. Today, myself, I'm joining you from North Vancouver, which is part of the unceded homelands of the Coast Salish peoples and the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. It is a beautiful part of the world, so please Google it if you don't know. Women's Health Cluster, probably many of you are very aware, but we have over 300 members now worldwide, which is fantastic, and community members as well as academic members as well. We run a number of events, trainees. There are lots of opportunities for you to participate in research presentations if you so desire, and there will be I hope soon, award. We call them travel awards. Obviously, nobody's really traveling too much, but hopefully that will change very soon. So take a look out for that. And there's a Tri-Cluster Research Day coming up. So if you want to present at that, you can. There's definitely awards there as well. We couldn't do this without sponsors, so please think about becoming a member and supporting us if you like what you see. And so with that, I'm going to end this, stop sharing my screen if I can. It is not letting me stop sharing. There it is. Stop share, stop that sharing so that Sophia can share her screen as you're done listening to me, and I'll read out her bio. Dr. Sofia Ahmed is a professor in the Department of Medicine, Cumming School of Medicine at the University of Calgary. She's vice chair of the research of the Department of Medicine at the University of Calgary, a nephrologist and clinical scientist with a focus on sex differences in human cardiovascular and kidney physiology and outcomes. Dr. Ahmed is an advisory board member for the Canadian Institute of Health Research, Institute of Gender and Health. I know because I used to sit on that committee as well, and that's how I got to know Sophia. It's a really fantastic committee, and Sophia does so much fantastic work. She's the educational chair for the Organization for the Study of Sex Differences and is a sex and gender champion of the CIHR-funded Canadians Seeking Solutions and Innovations to Overcome Chronic Kidney Disease, a pan-Canadian patient-oriented kidney research network. She completed her MD and internal medicine residency at the University of Toronto and nephrology fellowship at Brigham and Women's Massachusetts General Hospitals in Boston. She completed her master's in medical sciences at Harvard University. If that wasn't enough, if all those other credentials weren't enough already. And she's a strong proponent of the importance of mentorship and fostering excellence in the next generation of kidney and cardiovascular researchers. I would even extend that to all researchers. She's a fantastic mentor. I know that because I've also sought advice from Sophia as well. As many of you know, I like to give out a fun fact. And my fun fact, Sophia's fun fact is that for her first job ever, it was at A&W, which is like a burger joint. And that was in the summer after her grade 10 or 10th grade, as you Americans like to refer to it. There was a mystery shopper from the parent company evaluating customer service, and she received a 10 out of 10 on the friendliness test. the first employee ever at that location to do so. And as a token of their appreciation, she got some sunglasses. Do you still, with the logo on them, do you still have them, Sophia? That is my question to you, and take it over from here.
Great. So thank you so much for that kind introduction, Lisa. And I'm so honored to be part of the group with you today. And one of the speakers of this amazing speaker series. So I'm obviously talking to you today about the menstrual cycle as a vital sign, period. Hopefully by the end of this talk, you will think so too. And I really encourage a lot of discussion in this. If you have questions, please put them in the chat, and we'll definitely make time for discussion later. So, and I can't seem to go forward. There we go. So you may be wondering why someone like me, who's a kidney specialist and interested in kidney and cardiovascular outcomes and physiology, is talking to you today about periods and menstrual cycle. So I just take a step back and we'll just talk about women's health in general in Canada. So many of you on this call will be well aware that the leading cause of premature death of women in Canada is cardiovascular disease. And a group of us put together this position statement about a year ago. Hang on, I'm having trouble. But, and when you think, actually, even when you look at global data, cardiovascular disease is the leading cause of death of women around the world. The good news is when you look at cardiovascular disease and mortality from cardiovascular disease over the last 40 years or so, there's been a significant decline overall, which is fantastic. And this is largely due to the great research work that many people in this audience have been doing and their mentors, et cetera, over the years. But when you look at who has actually benefited from this research, you see that there's disproportionate benefits and impact. So when we look at older people, meaning over the age of 65, this is American data, but it really does translate for around the world. And you can see that both males and females have had to decline since 1979 all the way to 2011. But when you start looking at younger age groups, so under the age of 64, you see there's this nice decline in males, and there's a decline, but a little flatter in females. And then when you look at the youngest groups, you can see that there's a nice decline in males, which truly actually starts to flatten out a little bit here. But really for women under the age of 55, or females, I should say, you can see that it's been pretty stagnant since the 70s. So this has highlighted the need to have sex-specific and gender-specific research in cardiovascular health, and really highlighted the reasons behind looking at female-specific factors that can contribute to cardiovascular health and disease. So coming back to that, and I'm sorry, I just realized I meant to start off my talk by highlighting that I am speaking to you from the traditional and current or present day territories of the Treaty 7 people of Southern Alberta. And Calgary is also home to the Métis Nation of Alberta Region 3. And I also want to highlight that throughout my presentation, I am aiming to use inclusive language. It's important to recognize that not just women, or not just cis women menstruate, but people menstruate, trans men, non-binary people, people of all genders menstruate. So I'm going to aim to use that language, and I'm also going to use the language from the studies that I'm going to cite, so not to make any assumptions about anybody else's data. So just to put that, I meant to mention that at the beginning. But also, so coming back to why does someone like me care about menstruation and menstrual cycles? So approximately 50% of the population menstruates at some point in their life. And if you assume a 28-day cycle and that someone menstruates 7 days out of those 28 days, that's 25% of the time, a 40-year reproductive lifespan, that overall is 10 years of solid menstruation. So I would turn that question back to you by saying, why shouldn't I care as a healthcare provider and a researcher about the menstrual cycle, regardless of what my job description is? So this is from the American Academy of Pediatrics, published in 2006, but I think still holds true today. And I took their, as you can see, their title, Using the Menstrual Cycle as a Vital Sign, for my title today. And just to remind people of basics. So again, 15 years old, but probably still true today. The average age of menarche, which is the the age at which a person has their first menstrual period, 12.43 years. The mean cycle interval, how often someone will have their period in that first gynecologic year, varies dramatically. So it says here 32.2 days, but really it can be anywhere between 21 and 45 days. And the flow length is usually 7 or fewer days. According to the AAP, menstrual product use is between 3 to 6 pads or tampons per day. And as we all know, there can be wide variation in that as well. What's important to recognize is the American Association or Academy of Pediatrics does say that this data is primarily derived from white American girls of a pretty good socioeconomic position. And so that this data may not apply to others across the US or around the world. They do highlight, though, that it is important to ask about the menstrual cycle because if a person is having menstrual irregularity, this can be a clue to a number of things, the most obvious being pregnancy, but really any chronic, acute or chronic illness, be it congenital, be it acquired, all of these things can cause menstrual irregularity. And I would like to highlight, they don't have chronic kidney disease here, but as a nephrologist, I can tell you that that plays a role as well. So that's American data, but what about in Canada? So this is a study from 2010 that uses data from 2000 and 2001, where using this standardized survey, the National Longitudinal Survey, the authors surveyed 1,400 girls using their terminology, between the ages of 14 and 17. So this is again around the turn of the century. And it was weighted to represent almost or over 600 girls who lived from coast to coast. And based on this data, the mean age of menarche in Canada now 21 years ago, 12.72 years, and the median age, 12.67, so pretty close. But you can see it depends on where you live in, or where these girls, I should say, lived in Canada. So they also divided the age of menarche or stratified them using definitions. Did a person have early menarche? And that meant, I don't know how they came up with this, before the age of 11.53, or late menarche after the age of 13.91 years. So I live in Alberta, so that's why the arrows are here. And you can see that there's a lower proportion of girls who answered yes to either or fell into either of these categories. But for example, New Brunswick, over almost a third of girls had early menarche versus in Ontario, that's where the majority of girls who had late menarche resided. There are other factors that were associated significantly, so statistically, I should say, with whether a girl had early or late menarche. And one of the strongest was household income. So those girls who had lived in households that had upper, middle, or higher income were less likely to fall in those two groups, certainly early menarche. Also, we talked about this, which province in which she resided, as well as whether she lived with one or both parents. So why are we talking, though, about age of menarche? Why does that matter? So in the last 2 years or so, there's been increasing interest in this, specifically in the cardiovascular disease realm. And so my talk today is really going to revolve around that. So this was a study using the Women's Ischemia Syndrome Evaluation data set, which many of you may have heard of. And they looked at the age of which a person had, so it was a group of women, 648 women, who were being assessed for cardiovascular disease, and specifically were undergoing a coronary angiogram. And this is a way to assess if she has any blockages in her cardiac or coronary arteries. They asked these women, at what age did you first have your period? And then that is the exposure, and their outcome was whether this woman had a major adverse cardiovascular event over the next 6 years. And you can see that compared to the referent group, which was having your first period at age 12, there was a significant association between having a very early period, so specifically under the age of 10, or having a later period, meaning having your period first after age 14 or older. Those things were after adjusting for all the other things that the usual things that one adjusts for and risk of cardiovascular event. Age of menarche was a significant factor, specifically early menarche, but late too. So we've talked about menarche, and there are other studies that have supported their findings as well. But what about menopause? So menopause is when someone stops their menses, and menopause is defined as the absence or secondary absence of a period for 12 months. So that's how you define menopause. So we know that having early menopause is associated with decreased survival, and specifically cardiovascular survival. But but not all menopause is created equal. And this is a whole other talk about menopause, and I'd be very happy to have a discussion about that later. But this was a study looking at association of the age of onset of menopause. And specifically, they looked at women who had menopause before the age of 45. And so they stratified women, menopause before 45 or after 45, and looked at whether that was associated with a cardiovascular outcome, meaning having a heart attack, meaning having a stroke, or meaning the person died because of a cardiovascular event. And you can see that, so these are studies looking at coronary heart disease as an outcome, stroke risk, that women who had, menopause for whatever reason before the age of 45 were significantly more likely to have coronary heart disease, stroke risk, and increased risk of death. All-cause death, cardiovascular related death, stroke related, actually not stroke related death, but coronary heart disease related death. So there appeared to be some significant correlation, and this is not something that is commonly captured in the routine data sets that are used for big cardiovascular trials or studies. So what about reproductive lifespan? We've talked about age of menarche, when periods start. We've talked about menopause, when periods stop. But what about, maybe it's not each one of those individual life events, but maybe it's the time in between that matters. So the reproductive lifespan is just the age of menopause minus the age of menarche. And so this was a study, again, just over a year old, looking at 12 different studies where they pooled individual patient data, where they had data on when people started their period and when they had stopped their period, and whether they had a cardiovascular event or not. And I don't have a nice graphic from that study, so I've just put together this slide. But basically, they took having a reproductive lifespan between 36 and 38 years and menarche at age 13 as being the referent group. So you could kind of think of that as being like the healthiest group, or this is what the authors assumed. So relative to this group, those women who had a reproductive lifespan less than 33 years and menarche less than 11 years had, you can see, a hazard ratio of 2.06, so really twice as likely to have a non-fatal cardiovascular event. So suggesting that there's some interaction between these two terms. So having early menarche and short reproductive lifespan puts that, is associated with higher risk for that woman. So we've talked a lot about reproductive lifespan, when periods start, when periods stop. But what about what happens during that reproductive lifespan? So, menstrual cycle regularity, how regular are periods, and how long are the cycles? So meaning, what's the time span between each menstruation? Is there any association between those factors and cardiovascular risk? And specifically, this study was looking at premature mortality, and they define that as dying before the age of 70, which I don't think anyone would argue that is definitely premature, particularly for a woman. So what they did is they used the nurses' health study cohort, and many of you in the audience will be familiar with this, but for those who are not, so the nurses' health study is an absolutely incredible data set. So it was started in the 70s, where it was a group of nurses in the United States who were recruited to be part of this prospective cohort, and it's now been followed for over 40 years. These are largely, by definition, highly educated women. They're largely white, and by definition, they're all American. And basically, every few years, these women fill out very detailed health-related data surveys. They come in for physical exams, they give blood, they give urine studies. And there have been multiple studies that have come out as a consequence of this excellent data set. So these investigators used the Nurses' Health Study 2, so the second generation of the Nurses' Health Study. So followed women between 1993 and 2017, so almost 80,000 women. And they asked these women to comment on their menstrual cycle length and regularity at 3 different time points of their life. So in the teenage years, in the early adulthood years, and a little bit later in the adulthood years. And their outcome was all-cause and cause-specific premature mortality. Now, this is really hard to read, though I suppose everybody's looking at their individual screens, so it's not so bad, but I just wanted to highlight or put the table on here so you can see the number of factors that, or the richness of the data set. I also want to highlight that, so basically these women were in their 30s. As I said before, most of them are white, very few smokers, not, BMIs in the 25 to 28 range, pretty active, and low risk of hypertension. So really, this is a healthy data set, which again, may or may not be represented or is not representative of the rest of the American or probably the Canadian population. When we look at how these women classified their cycle regularity and cycle length, the majority of them had what they considered very regular cycles. And I'm blanking on what that definition was, but the study investigators did define what that meant. And then when you looked at the cycle length, the vast majority had, so this is again, the number of days between the first day of each period, 26 to 31 days. And you can see followed the next most common categorization was regular, as well as having a cycle length less than 25 days. Again, this is a big figure to really go through, but I really just want to bring your attention to, here we go, that those people at any age group, so in the teen years, in the early adulthood, in the later adulthood, those women who had irregular or no period were the ones who were the most likely to be most likely to have a premature death. When they looked at cycle length, we can see that it was the women who had the longest cycles, so 40 or more days between periods, who had the highest association with a premature death. I want to highlight that there is some data on oral contraceptive use, which the authors commented, and I agree with this, it's a little bit difficult to know what to make of that, because a lot of women take oral contraceptives because they have irregular periods. So is whatever the outcome is in the oral contraceptive users, is it because they were taking the oral contraceptive, or is it because of the underlying reason that they were taking the oral contraceptive? And we don't know that answer, but it is something I think was quite interesting. Many people in the audience, because I'm totally switching gears here, sort of. I don't know if there's anybody here in the audience who is a soccer or football fan. I am, but I don't think you had to be to know about this. So the United States women's national team won the World Cup 2 years ago, a soccer World Cup. And one of the things that got a lot of press after their win was the fact that they tracked their menstrual cycles through in the years leading up to the World Cup, in order to optimize their athletic training. So they would change what they were doing and individually within like per athlete, depending on where she was in her menstrual cycle. So she would lift weights on one day, or she would do endurance on another day, etc. And so this was seen as a real step forward for women's athletic performance. Finally, we're taking female biology into account when, designing what is the way to optimize a person's performance. So, which sounds great. And I've just lost my cursor. There we go. Except, I shouldn't say except, and I was one of those people, I thought, oh, this is fantastic, until I read a blog written by Dr. Sarah Richardson, who is at Harvard University and leads the Gender Sci Lab. And I'm if Dr. Richardson, if you ever watch this, I'm trying to paraphrase your amazing research, that basically looks at the origins of where we as scientists come up with, or what assumptions are we making when we move forward with our research. So she highlighted in her blog that this is wonderful that the US women's national team is, taking into account the female menstrual cycle when planning athletic training, but we're making the assumption that the female menstrual cycle actually affects athletic performance. And when you actually look at the data, and I think Dr. Doyle Baker is in the lab, so please correct me if I'm wrong, it's somewhat controversial. It's not clear that there is definitely a connection between these two things. And so really what we're doing by saying, yes, it's great that we're tracking the menstrual cycle with performance, or in the case of whatever type of research you do, or in my lab, it would be in our human physiology, or cardiorenal outcomes, we're assuming that the menstrual cycle has an impact on our outcome. But is that really true? So said another way, does that mean that a person who is menstruating or who is premenstrual, are they truly operating at a deficit? Because that is the assumption we're making when we do our research. So basically, any time that someone's in this phase, that, well, they're operating at a deficit. So anyway, here's the link to the blog if it's of interest to you. So Jennifer Williams, and Jenny, if you're in the audience, I'm a huge fan of your work. Jennifer Williams is a PhD student at McMaster and published the systematic review late last year, looking at the impact of the menstrual cycle on peripheral vascular function in premenopausal women. So basically, oops, lost my cursor again. There we go. Looked at female participants, and Jenny, if you're in the audience and if I say something wrong, please correct me, but basically looked at both the early and late follicular phase to see if whether a person was participating in the research study during one or the other phase, if this had an impact on the outcome. And here it is for macrovascular outcomes, here it is for microvascular outcomes. And she said it best, is that the menstrual cycle appears to have a small effect on macrovascular endothelial function, but not on microvascular or vascular smooth muscle function. However, these results can be partially attributed to methodological differences. So basically saying that, and not surprisingly, all of these studies are done differently. People are recruited at different times of the year, different times of day. And whatever is done on them is done differently. So really, again, Jenny, correct me if I'm wrong, it's hard to know. We don't actually know that the menstrual cycle has an impact on these things. So what do we know? So the menstrual cycle maybe doesn't change the vasculature. Maybe that's too strong a statement there. Early menarche and shorter reproductive lifespan is associated with increased cardiovascular risk, and irregular periods and shorter cycles are associated with increased premature mortality. And I said, what do we know? But I really want to put an asterisk. What do we think we know? And it's important to take a step back. These are all association studies. Obviously, you can't randomize someone to having short reproductive lifespan versus long reproductive lifespan. So, it is important to recognize these are associations and they're important to look at, but is that truly a cause and effect? So I also want to take a step back that there's probably a lot of people in the audience who are, thinking of their own reproductive history or that of someone they care about and going like, oh my God, I'm doomed because I fit into category X, Y, or Z. And I really want to stress that we don't know. So please don't think that way. And this is why you're all here and we're going to do this great research. So what are other things that could account potentially for the associations that we're seeing between these exposures, short reproductive lifespan, early menarche, et cetera, and our outcome, meaning cardiovascular disease and death? And I'd like to point out, I'm a kidney specialist. There are some studies that suggest there's increased risk of kidney disease as well. So you could probably insert kind of any disease in there as your outcome and find an association. So I just want to highlight the financial stress that is associated with menstruation, as well as pain and decreased quality of life, which then further leads to financial stress, as well as stigma that is associated with menstruation. So I have taken the liberty of looking at the Safeway website. Safeway is a grocery store that is probably one that's closest to my house and where I go the most often. And so this is what is listed as the cost for Always pads. And this is what is listed for Tampax. I decided to go with brand names. So when you divide up, it's 23 cents a pad or 24 cents a tampon. And again, remember the American Academy of Pediatrics suggested that people use 3 to 6 per day, at least in the adolescent years, as part of their period. So just assuming that, then this costs about a little over $10 a month. And depending on where you live in the world, you may have tax on that as well. I did not calculate in tax. So assuming that you do that over 12 months, that one period per month, it's about $120 per year. So then I looked at the Alberta government. Again, I live in Alberta. This will not apply to each province, but I suspect it's a similar situation. So the Alberta government provides AISH, and that stands for Alberta Income Supplement, and I forget what the H is. I'm blanking on it right now. And it's for people who live financially below a certain level. And so the government provides this monthly living allowance. And currently it's just over it's almost $1,700 a year. If you have a child, it's $200 extra per month for the first dependent child and an extra $100 per month for each additional dependent child. There are some supplementary funds that are available to the client for some health-related personal benefits, which include things as varied as arch supports, orthotics, CPAP for those who have obstructive sleep apnea, service animal supports, if you need a special light for seasonal affective disorder, et cetera, et cetera. You will notice that there's nothing here about period products. So that is not considered a personal benefit or a health-related benefit. So essentially what that means is that if you are someone who's assigned female sex at birth and or you have a child or more assigned female sex at birth, you have a financial penalty just by virtue of your biology, and there's nothing you can do about it. So you've probably seen this referred to as systemic level sexism, the pink tax. It has lots of names. So basically it's a financial penalty for having XX chromosomes. So what about primary dysmenorrhea? So we already know that, so there's already a cost.
That was like textbook perfect. What was it?
Well, thank you, whoever said that. So then moving on to primary dysmenorrhea. So basically that means pain with menstruation. So this is really common, as you can see, affecting at least, if not almost all people who menstruate. And I'm using the terminology from the studies, but really it should say people. Oops, hang on. Of these people, 10 to 25% have severe primary dysmenorrhea. And this, I mean, when you're in pain for whatever reason, clearly this has an impact on your life. So specifically these things, dysmenorrhea has been found to have negative impacts on family relationships, school, work, social, recreational activities. I am sure there are people in this audience, either you were that person or you knew someone who missed at least 1 or 2 days per month of school growing up because of their period of period pain. And so that's continues a lot as people move on into the work world. So 34 to 50% of people have said they've had absenteeism as a consequence of dysmenorrhea. And they lose 1 to 2 working days per month, or a significant proportion of people. It's been estimated that this costs 600 million working hours, or $2 billion per year, which is a lot. I think we would all agree on this. The period stigma also disproportionately affects people who menstruate around the world. So, there are, sometimes when people who are menstruating for religious, cultural, familial reasons, they are excluded from participating in activities, which clearly has consequences as well. And one of the more extreme exclusions this happens in Nepal, called the menstrual shed, which are illegal, but are still happening. So basically it's a shed that's constructed outside the family home. And the person who is menstruating has to stay there throughout the cycle during which they're menstruating. And there are often people who will die because of cold, or they'll die because of smoke inhalation, et cetera. And so it's a pretty extreme example of exclusion or a period stigma. So when we think about period stigma or period poverty, it's easy to think of this as a global, or something that doesn't happen in, I'll use the word in high income countries, only in lower and maybe some middle income countries. But the truth is it happens everywhere. So this is a study that just came out a few months ago. This is in lower income communities in the United States. I think this one's Louisiana, and just highlights percentage-wise the number of people who menstruate, how many days per month they miss of school, partly because they can't afford period products, partly because of pain, and the educational and economic opportunities that are lost as a consequence of this. So this is certainly not just a low income country problem, but certainly a global problem. Oops. If you Google, you can actually find a whole pile of comics that kind of highlight this. And I'm sure there's lots of people in the audience who can identify with this. You never mention that you're staying home because you have period pain. People always come up with another reason. They have the flu, et cetera, et cetera. It's not something people talk about. And there was an actual study that looked at this as well, because it's important. It can't just be anecdotes, but you want to have percentages and facts. So about half of, this is a study out of the United States, I believe, just over 1,500 women and 500 US men, so people who menstruate, but they say women here. So about half of people feel embarrassed when they're on their period. Over 40% feel they've been shamed for their period. Almost 3/4 hide menstrual or period products from view. Yet almost 100% of people who identify as women, according to this study, have periods. So, this is normal biology, and yet there's such stigma and no one wants to talk about it. Thankfully, this is something that is changing in Canada, and this actually happened at the beginning of the pandemic. A group of young teenage girls and young women in the Toronto area have started National Period Week, highlighting that depending on which study you look at in Canada, 1 out of 3 or 1 out of 5 women under the age of 25 cannot afford period products. And they're too afraid to ask for help about it because there's such stigma. So, so you would think, okay, there's all this, conversation around this. You would think people in the healthcare sector would be really, maybe not everyone's aware of, concerns or women's health or period stigma, et cetera, but hopefully those who are healthcare workers would. So this is a study that came out of U of T, Drs. Anderson and Gagliardi, who have done a lot of work in this area. So they actually surveyed all 17 medical schools in Canada, asking them for their documents for the undergraduate medical school curriculum to see what mention, if any, there was of women's health. So this could include sex and gender differences. This could be women health concepts, specifically female reproductive, basically anything to do with women's health. They got 16 of these schools, so only one didn't respond, and a total of, I think it's about 1,600 documents. And so they went through them and they found that a grand total of 8.6% of these documents had any reference to women's health, sex differences, et cetera. And actually, when they looked at it more specifically, it was determinants of health that had the most references to women's health specifically, but not so much just differences in hypertension, nothing about women, or sex differences in knee replacements, no mention of that. So we have work to do is a short answer. The good news is this came out in 2016. Newsweek is obviously a US publication, but there is real pushback on, I'll say, societal norms, like there will be blood and we need to get over it. And that period stigma is not only something that maybe people don't want to talk about, but it's really hurting the economy, schools, and the environment. And I'll throw in health care. And so there was a lot of pushback based on this cover, but it did get people talking. So have we decided that age of menarche, menstrual regularity, cycle length, reproductive lifespan, these are all risk factors for cardiovascular disease and death? And I would say, despite these outstanding prospective cohort studies, observational studies, that the jury is still out. I don't know that we can say that there is definitely a cause and effect at this point. So how are we going to get there that we can identify whether this is an important, I'll use the word risk factor for future cardiovascular disease and death? And so I would propose a roadmap that we can all employ. So if we are a researcher in our studies, let's control for the menstrual cycle, or at least write down, record what stage the participant is at in the menstrual cycle. Talk about, or ask about the age of menarche, the regularity, duration of their periods in the cycle. What is their menopausal status and why did they become menopausal? So we could have a whole other talk about a surgical menopause versus a natural menopause versus a chemotherapy-induced menopause. These all have impact on future health. And of course, reproductive lifespan. If you are someone who is also or is in the clinical realm, definitely ask about periods and all that comes with it, financial, social, physical, mental, because all of these things have an impact on the person in front of you's health and health outcomes. So it would be important for clinicians to incorporate that into the clinical record as well. And certainly have a low threshold for referral if help is required. And so that brings me to the end of my talk, but this is my last slide. So Danica Chang is a master's student in our lab who is doing a worldwide study looking at people who live with kidney disease who are born with a uterus to ask them about their reproductive health. So if you are someone who lives with kidney disease or you know someone who lives with kidney disease, please feel free to pass this survey out. And that's it. So thank you very much. And I'd be delighted to start with the discussion. So thank you. I'll stop sharing now.
Thanks so much, Sophia. For those of you that, thank you. I was just going to say, I feel like it, please put those emojis up. It's always nice to see some visual confirmation in this virtual world that we live in. And please do put tell me that you have a question in the chat, and I think you should be able to unmute yourself and ask the question. Otherwise, I shall start with a question, or I can ask my question to you. But so I'm going to go right to the Susan Richardson thing, and I haven't read the blog, so it's interesting, but. And I understand that it's really important for us to think about, why are we asking the question? But if we don't ask the question, we're not going to know. So I'm also thinking about the COVID-19 vaccines. And then, people suggested, hey, I'm having some disruptions. It was short-lived. I'll disclose I had my own disruption that was very short-lived, but it was very short in time duration from my vaccine both times I had it. Again, anecdotal, but it's important to ask these questions so we can figure out, doesn't matter. And if we don't ask, then we're not going to know. So and it also suggests to me that if there is a difference in, risk, sorry, I've totally forgotten Jennifer's work, but like micro or macrovascular, whatever, does that mean that we might need different treatments depending on what phase of a cycle that you might be on? I don't know if you want to. So I'm just pushing back a little bit on the, oh, we shouldn't, because it almost sounds like we shouldn't look, but then if we don't have the research on it, we're never going to know.
Yeah, Lisa, I think you raise a really good point. Not knowing, the absence of evidence is not the same thing as evidence of absence, right? Like just because there are conflicting, that's the word I'm looking for, studies that saying, for example, menstrual cycle and athletic performance. I think that I'm not an expert in that area. And I think Tish, are you back? Because you can chime in on this. Dr. Doyle Baker is a kinesiologist, a PhD professor of kinesiology at the U of C, and I'm so excited she's here, and this is what she does in her lab. But basically, just because that there's conflicting studies, I mean, who knows what's the right answer? And I agree with you, Lisa. We need to systematically incorporate these factors into our research in order to be able to answer those questions. Because it's kind of dangerous both ways, right? Like if we assume someone is operating, to use Dr. Richardson's words, at a deficit, if they're in the premenstrual phase or the menstrual cycle.
Yeah, so where does that come from? I think that's a bias in of itself, to think that like, oh, some certain phase is coming from a deficit. Like, I don't think that way. It's just different. It's like when we see differences between the brain, between males and females, and Tish just looks like she, so it looks like she has something to say, but I always think that's fascinating that people automatically assume one sex or one phase is inferior to the other. That's not what it means. It means they're different. And that's what we should be studying. Like, how is that affecting our norms? You know, if you're trying to get blood pressure or something, how does it affect the measures we're taking? And do we need to consider that? And we're not going to know until we look. And Patricia, I think you go by Trish. You're muted.
Yes, I am. Most people like me that way. So I missed a little bit of the conversation, so I apologize to everyone, but I always like to start with this one quote from Paula Radcliffe Jones, and she's arguably was one of the best, until very recently, marathon runners. And, she made this quote, I had 2 kids and I've never had any problem with my menstrual cycle. And I've performed on a day where I think she even said that she broke the world record for a marathon running for a female on the day that she had her menstrual cycle. But, we're all very different. And there is not really a lot of research out there for us to draw evidence from, partly because of our methodological approach to what has happened in the past. And we have a lot of individuals over in Britain, Christy Elliott Sales, who probably right now is producing the greatest number of papers in this area. And, we have a lot to do methodologically if we really want to make a statement on whichever side of the camp you are on 2 phases or 4 phases or 5 phases, or however you look at the menstrual cycle. I just don't think that we have enough research out there to make a definitive statement either way. And even if we did, we would still have to consider the lived experience of each individual associated with that. So, you can sort of say to yourself, why would you ever want to do research in this area then, based on that comment that you've just made, that you may never come to the right answer? And I suppose the reason is because it's really quite fascinating.
It's fascinating. And then that comment, well, it never didn't happen to me, reminds me of I think there's a proverb, and somebody can help me to tell me where it's from, but it's something like, it might be a Jewish proverb, something about like, these shoes don't fit. Somebody says these shoes don't fit, and the other person says they fit me just fine. Just because, same thing with the menstrual cycle irregularities following the vaccine. Well, I didn't have it, but that doesn't mean that other people don't. It does, but I think it's interesting to me that it becomes a political debate, because it is effectively about female health. And so, and important to study. We have so few, like Sophia, like that medical school curriculum, that like blew my mind, 8%, like that's just so small. And if people aren't asking, I mean, it's, it can be frustrating, right? So another thing I heard, and another seminar was something about like, periods don't have to be painful. Well, like, and I don't want to be anecdotal because like, we're just talking about how that can be bad, but I didn't know that. I missed school so much because my periods were really, really painful. I didn't know there was medicine you could take to get rid of that. And no, I wasn't offered any, when I went to my doctor. So I thought he has really great recommendations, Sophia, in terms of clinicians and researchers, because you're at least saying, hey, let's get the data. Let's look at it. And do you have any more advice maybe for researchers in terms of like, I don't even know about the two-phase, because I don't research this two-phase, four-phase, I don't know anything about that, but like what should people be doing in terms of researchers and clinicians, I guess?
So I don't want to pretend to be the expert. And if there are people in the audience who there are things, I'd love to know what your labs do, for example. So, what our lab does is we aim to have people come in 14 days after the first day of their last period, just as a way of standardizing, though I don't know if that's the right thing to do, because if somebody has say a 3-week cycle, well, we're 2/3 into their cycle. If somebody has a 40-day cycle, well, we're still in the first half. So we also measure estrogen and progesterone and testosterone levels as well, as to see if that plays a role. And then we do some statistical analysis. The only problem with the type of work that we do is like we have human participants who come in, and it's expensive to run. And Tish, you can comment on this as well. It's expensive to have, well, it's expensive. All research is expensive. I don't mean that, but it's not like you can bring a human in and say, okay, we want to do, like, people have lives. They are coming in between classes, or, they're taking a day off work because they want to contribute to science, or, like, you kind of work with what you've got. So I don't know if anybody else has any comments on things that they've done in their labs or things that have.
We have another question for the audience, but
oh, great. Okay,
so maybe we can go back to that if because I bet there's lots of different things that people are doing, but I agree that maybe a consensus piece. Okay, Natalie also has a very long comment, but Emma, do you want to ask a question out loud, or do you want me to ask it for you? I'm happy to ask it for you, but I'm going to assume that I'm going to ask it for you. So, a question for Dr. Ahmed. Do you know if people on birth control were included in the studies that you were describing? If not, are these people often considered in this area of research?
So Emma, that is such a good question. As another female specific potential, I don't say risk factor, but factor that can influence cardiovascular health. So I don't know is a short answer. Oftentimes that's not recorded. In our lab we do, or we stratify based on that. And I suspect everybody in this audience does as well. But many studies, they don't record whether the person's on the contraceptive or not. Or if they do, they just say on the birth control pill. And that's kind of like saying someone's on antibiotics, right? Like there's so many different types of oral contraceptives that all have different effects. We also don't know why someone is taking an oral contraceptive. So some people will take it for birth control. Some people will take it for cycle control, right? If you have really heavy periods or really irregular periods, the birth control pill can be a great way to normalize, regularize, I'm not sure if that's a word. And so, in that one study I showed in the BMJ from 2020, they showed some associations between oral contraceptive use and premature mortality. Well, is that because the woman's on the person is on the birth control pill? Is it because they're taking it to normalize their menstrual cycle? There's some people who will take oral contraceptives as gender affirming hormone therapy. And those people, wouldn't have a menstrual cycle. So that's a long answer to a short question. And I don't know the answer, but the best thing is, as I'm sure you do in your lab, is to write down what they're taking, when they started taking it, why they're taking it, and what's the composition of the contraceptive they're using. So,
Natalie also, there she goes, has a question.
Hi, thanks so much for your talk. It's really fascinating. I had a question from someone who does in a lab that doesn't specialize necessarily in women's health or menstruation, but I study pain, and we know in the pain field that the menstrual cycle can affect your pain thresholds. There's sort of conflicting about that, or a chronic pain condition. And anyway, the barrier that I've come across is that even if we collect data from our participants who are menstruating about their last cycle or their oral contraceptives if they're on it, that anything short of sort of serum confirmed like blood work or something to confirm which stage of the cycle they were in, it's not going to be acceptable. So I'm just wondering if we're trying to push all these different fields of research into including cycle data in their analyses, if there's sort of like an acceptable way to collect that information that the experts deem as reasonable. So like the period tracker apps, or I know like the Apple iWatch was collecting that information, just to start like lowering the barrier so that this is included in more research.
I think that's a great question. I'm going to let the experts answer it, but I would just say that in animal data, we have the same problem with estrous cycle. I'm like, oh, you should, you need to do lavage or you need to do blood. And I think the thing is, you just keep pushing for what you may have. But do you, Sophia, Trish, do you have any thoughts on that?
Tish, do you want to start?
Sure, thanks, Sophia. Well, I mean, it's interesting. I'm have a grant in for review right now. I'll call it a grant proposal now. I thought it was a pretty sure thing. And one of the reviewers, really hammered me about our salivary methodology. And I think that we've got two situations going on. People from a methodological perspective want you to do the absolute best, and I understand that. But if we do that, because of the expense of that, we're not going to be able to collect data on a number of people from a big sample size. So we kind of get stuck in that sort of scenario. And then on the other side, we're talking about menstrual cycle apps, which is a really interesting point that was made. And then I guess the question is, I guess I'm going to go in a circle. How good are the menstrual cycle apps? And I'm involved in a study right now that's, trying to validate one. So we're still caught in this vicious circle of what is methodological rigor and what we would consider that is scientifically valid.
Yeah, I agree with everything that Tish just said. I've certainly had grant reviews that, have criticized what we're doing, and they might be valid. It's just, I don't even know what I don't think anybody knows what the gold standard is. And oftentimes I think the people who might be the most critical of collection of this data are those who don't do it. So that's been my experience.
So I can't think of a better way to end this 1-hour session than that. I mean, there's always ways you can, Natalie, I think it was Natalie, that asked the question that you can push for things, right? So, I mean, sometimes reviewers aren't going to accept it. Sometimes they will, grant reviewers or paper reviewers. And the point is to include the data you have and with the limitations, right? We chose this method because of, for these reasons, and here are the limitations to this particular method, because nothing's going to be perfect. Nothing is, right? Because our periods aren't perfect. They're not all 28 days long. We don't even always ovulate during each period. So there's also that. So with that, I just want to big thank you to Sophia, and obviously Dr. Patricia Doyle Baker needs to come and give a talk in the next round. But it was really fantastic to hear, and you really showed us so much important information on mortality, cardiovascular disease risk, but also all the way to stigma and medical school curriculum. It was fabulous. I had some other comments, but I'll have to ask you that in person, privately. All right, well, thank you so much, and join me again in thanking Dr. Sophia Ahmed. Thank you so much.
Thank you, everyone.